The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric with you. Today we're going to do a really good Nightmare Series podcast, but before we do that, I just want to discuss or talk about the SMAC conference and in my experience with the SMAC conference. But before we do that, I do want to say that our deepest condolences need to go out to John Hines and his family. Dr. John Hines, if you don't know, is a phenomenal doctor. He's been a great mentor for me. He's part of the Rage podcast. If you haven't ever checked out the Rage podcast, Dr. Hines is out of Ireland, Dublin, Ireland, and he's one of the top guys in trauma, in progressing trauma. One of his big passions, if not his biggest passion, was he was what's called a flying doctor. And him and another fellow physician would ride on these super bikes, following these road races in Europe, and he would follow them real close behind on all the practice sessions on the first laps, and then he would be prepared to respond if there was ever a crash, and he was able to get there, within seconds because of his ability on these super bikes. Unfortunately, though, right around the first of the month, about a week after we were all returned from the SMAC conference, he was killed in a motorcycle accident during a practice session in Ireland. So that's very surreal for me, just getting to meet him and hear him speak and see his passion. It really shows and just reminds us that, even though we see patients die every day, we take care of these patients, it's a little bit different, I think, when you see a colleague, a mentor pass away like that. It just reminds us how life is precious, and we really need to take every opportunity to make every interaction with our friends, our peers, our family count. And I think one of the things that I'm constantly reminded of is, because of our personality and our desire to succeed in our careers, it's really easy to sacrifice our family and not realize that, we have to invest just as much in our family than we do out there in the field. So just take that, think about that. This has been a tough week for the FOMED world, pretty tough. So as far as the SMAC conference was excellent. Like I said, if you've listened to our new podcast, Second Shift, I want to thank you for that. I want to thank you for taking the time to download that and subscribe it. If you haven't, go on to iTunes, go onto the website, and just, if you're going to go onto iTunes, search Second Shift and subscribe to that. We would be very, very appreciative. The SMAC conference was excellent. Like I said, got to see some great lectures, some new innovative ideas. Got to hear, like I said, John Hines speak, and Cliff Reed, Scott Weingard, all the big hitters in the FOMED world. So that was really, really good. If you're a new listener to the FlightBridgeED podcast, I want to thank you for coming on, for subscribing and checking out the podcast. And what you're going to find, if you go through all these different podcasts, I think this is going to be number 62. This is a very highly practical podcast. This is something where I lay things out that you should be able to apply immediately to your clinical practice. And we really try to build on every lecture that we apply or we teach. You're going to find that I'm very passionate about specific things, airway physiology, oxygenation physiology, and really passionate about being a resuscitationist. Not just being a paramedic or a nurse, but really thinking 5 steps ahead and thinking about stopping that decompensation from ever happening. And I think that's the mindset we have to take. If you've been a listener from the start, I want to thank you. Real appreciative of that. And my whole goal is to invest in others and to build everybody up and bring everybody up to the highest level. And this does the same thing for me. It forces me to constantly study, constantly try to learn new things, keep on the very top edge of what's going on in the FOMED and emergency medicine world. So I want to thank you for that opportunity as well. Like I said, today we're going to go through a Nightmare Series podcast. I've wanted to record this podcast for a long time. If you've taken our review courses, you've heard a little bit about this, and so this is going to be fun. This is a flight that I was on about 4 years ago with a good friend of mine, Tony Harrison, and this is a Nightmare Series patient in flight delivery. So I'll kind of lay the stage. Like I said, this is about 4 years ago. We've been in contact with the mother many times. She's given us full permission. We've changed a few things on this scenario, but we've got pictures of the baby, of the little guy. So I'm going to lay out this podcast, and what we're going to do is we're going to look at this from the perspective of a transport and what could go wrong. Kind of talk about the different decision-making paradigms you can go down. We'll look at the OB aspect, and we'll look at the neonate aspect. So this is kind of in the middle of the summer. You respond to a smaller hospital OB unit for a OB transfer, and you're about 45 to 50 minute flight by rotor aircraft to a hospital that's got an OB unit with a neonatal intensive care unit as well. You're flying in a Eurocopter EC130 aircraft. You arrive on scene and you have a 21-year-old female patient. She's Gravida 1, Para 0. She's had no past medical history in the past. She's very, very healthy. She's had current prenatal care throughout the whole pregnancy. She's currently 30 weeks gestation. So when we go in on transfers like this, I think the big thing we have to think about is, do we fly a active patient in labor? And there's different definitions of active labor. Remember that there are stages of labor. The first stage of labor is essentially that cervical dilation, the effacement. Remember, cervical dilation is the amount of, or I should say the size of the cervix based on centimeters from 0 all the way to 10. And then effacement is the thickness of that cervix. Is it thinning out? And once it gets really thin, you're more apt to deliver at that point. And then the second stage of labor has kind of 2 stages based on that. And you have the first stage, which is crowning, and the second stage is actually when you have active delivery of the baby. And then we know the third stage is actual placental delivery. So when we have a patient like this, what is a patient that's stable enough to fly? And oftentimes in the HEMS world, we don't really look at stability as far as, do we fly this patient? Obviously, they're not doing good at that location. There may be a few cases where they need to be a little bit more stable, but very few patients that you look at and say, we can't transport this patient. That's why they're calling a critical care crew like that. And that may be different with the different agencies, but I know the agency I'm in, that I fly for, that's not the case. So usually the protocols will state that if the patient is having contractions every 5 minutes or within that 5 minutes, that's probably not a good patient to fly. But again, that all is dependent on clinician judgment. That doesn't mean that's a hard and fast rule. Now, I can say that in this case, for me and my partner, Tony, we flew a lot of patients from this hospital that were in active labor, contracting every 5 minutes, and never had an issue at all. So if we continue, you're on scene, you get report from the physician, you get report from the nurse. The big things you want to make sure is, have they checked for dilation recently? Never leave a patient, or I should say never leave the hospital with a patient that hasn't had their dilation checked in the last at least an hour. I would say 30 minutes, because a lot of things can change. What's the effacement? So she was 2 centimeters dilated. She was 50% effaced. She's currently contracting about every 10 minutes at this time, and they're lasting about 30 seconds. So again, this patient is, to me, very flyable, very stable. She had her membranes rupture that morning when she woke up. As far as looking at the baby when you go in on a transfer, things you want to look at: is the baby bradycardic? Is the baby tachycardic? What's the variability? Variability is going to be the biggest, single most important predictor of fetal well-being. So remember, we don't want poor variability, and poor variability is going to be basically they're having no increase in heart rate based on the contraction. And you can always think about poor variability being a cause or a secondary cause related to hypoxia of some sort. So fetal hypoxia, as the mom had been given medication, is going to depress the respiratory drive. Does the mom smoke? Is the baby really premature? Obviously this baby's 30 weeks gestation, so 2.5 months early. Or it could be just a simple pediatric, or it could be just simply fetal sleep, as the baby is sleeping at that time. Like I said, you want to make sure you have good variability. And the biggest thing we want to look at is what's called accelerations. Accelerations essentially are you're going to see a heart rate increase at the very start of the contraction. So that heart rate's going to go up, may go up 5-10 points, may go up a little bit higher. But that contraction starts, and during that contraction, the heart rate's going to come back down. So it's just a really quick increase in heart rate. At the beginning of contraction, that heart rate increase isn't going to last very long, and it's going to go back down to that normal range. And your normal range on fetal heart tone is probably going to be 120s on the low side. Probably 150 is going to be a great norm in that range. So at this point, we move the patient over to the gurney. We're given a very thorough report by the physician. Patient is being given all the standard medications. So let's talk about that. The first medication you're going to often see is breathine. Breathine, remember, is terbutaline. And terbutaline we use for multiple reasons in critical care. One of the common reasons is in asthma. And breathine is a beta-1 stimulant, right? It's a beta-1 agonist. But the other aspect of breathine that we have to remember is it's got very good smooth muscle relaxation. And it works really, really good at relaxing and stopping that contraction of the uterus. So breathine was given at 0.25 milligrams sub-Q. Betamethasone. Betamethasone is a steroid, oftentimes given in preterm labor for the baby, kind of to help stimulate those lungs. So she got that. And then our big medication that we always see is a tocolytic, and that tocolytic is mag sulfate. Remember, if you've taken your FPC or your CFRN, the big thing with mag sulfate is you want to watch that closely. You do want to check your deep tendon reflexes often, at least every 15 minutes. And so this patient had been given 4 grams bolus, and she was on a drip at 6 grams per hour. Now, there may be times where you're able to get a mag level, and they're going to try to keep that mag level as high as possible. And I think it's right around 7 as far as a mag level. If they've checked it, if the mom has been there for any time, they should be able to give you what the mag level is. And again, it's going to be on that high range. So really easy for these patients to become mag toxic. Other things that could show mag toxicity is respiratory depression. MAG will cause respiratory depression. So anything like that, if you lose your deep tendon reflexes, if you lose your patient's ability to breathe, or you see some depression there, obviously we want to stop the MAG and wait and see if the patient responds. If that's the case, then everything's going to be good. If not, then you're going to have to give some type of antidote like calcium gluconate or calcium chloride. So at this point in the scenario, we're packaging our patient, and one of the most important things we have to do is do what's called a fundal exam. And a fundal exam is something where it tells you a lot of things. And the best way to kind of explain this over a podcast is what you're going to do is you're obviously going to talk to the mother. You're going to introduce yourself. Whether you're male or female, you need to do this. And what I always do is I'll pull the blanket down as low as the pubic bone, and I place my hand right above the pubic bone. And what I'm trying to do is I'm trying to feel for the baby's head. And so you're doing that for a few reasons. Number one, you're doing that to make sure that the head is down. You want to know the head is down because you don't want to breach baby, right? And then once I have the head in my hand and I'm kind of, you're being gentle, obviously, you are going to have to push a little bit. I'm going to start palpating each side of the mom's stomach. And what I'm trying to find is I'm trying to find the hard side. The hard side is going to be the baby's back. And that's important, again, for a few reasons. Number one, it confirms that the head's down and the back is where it's at. And number two, it tells you where you're going to listen for fetal heart tones in the helicopter if you need to do so. I'm going to confirm that. I'm going to palpate on the opposite side, and that side should be very squishy. You should be able to push in quite a bit, and that's the stomach side of the baby. Now, based on how the baby is lying, if the head is down and the back is to the patient's left, then that's documented as left occipital anterior, or LOA. That means the occiput is pointed to the left, head is down, and so that's how you would document that. And you're going to document just the same if the head was turned the other way and the back was to the right. It would be right occipital anterior. And so in your charting, you would just write ROA, and that, again, lets everybody know that you did a good exam. You identified that the head was down. You identified where the back was to listen to fetal heart tones. So at this point, we have moved the patient to the aircraft. The husband has decided he wants to go with us. And so we load everybody up. We give a safety briefing, obviously. And like I said, we're in an EC-130. So if you're not familiar with an EC-130, EC-130 is probably my favorite single-engine aircraft. It has a lot of room to access the patient. You can pretty much access the patient from head to toe. You can move around both sides of the patient, and it's got a lot of power for a single-engine aircraft. Very, very good visibility as far as the cockpit. So, great aircraft. You load the patient up, you lift off, and so now we're about 10 minutes into the flight. And you and your partner, we're conversing. Tony and I are talking. Husband is sitting behind the pilot. I'm sitting next to the right side door. Tony's sitting in the middle. She starts acting like she's very uncomfortable at this point. So, I start talking to her, and, it's really hot. It's a real hot July day, very humid outside. We end up wetting some towels with a water bottle. We put it on her forehead, and she just states she's really uncomfortable, and we start talking to her about the contractions. And I calculate, and her contractions have gone now from every 10 minutes down to every 2 minutes. So at this point, I'm kind of starting to have my red flags up. If you know Tony's real laid back like I am, and I think he was in just as much denial as I was. He's just sitting there and talking to the husband. He's talking to me, and I don't think either of us really thought this was going to happen. So I decide to go down to the bottom of the gurney, and I do kind of a visual vaginal exam to see that, make sure we don't have any crowning or anything like that. And I do note that there's now some new bloody show. And so, again, I go back up, sit in my seat, and identify that, this may happen. So we start talking to the pilot, and that's, again, communication in the aircraft is huge. Talk to your pilot, find out where we were at. We happen to be about 7-8 minutes from Campbellsville, Kentucky, and we pilot made a decision. We told him, why don't you start heading that direction? We were still about 35 minutes out from the NICU. So at this point, I came up, I talked to Tony and let him know what I saw, and started talking to the patient again. She immediately went from contracting every 2 minutes to being extremely uncomfortable. I mean, she went from laying there sedentary when we loaded her in the aircraft to now she is actively wanting to push. And this happened within, I'd say, a minute and a half. So this is a big aspect of a precipitous delivery or imminent delivery. And we have to remember, you got to try to be prepared in this situation. Right, have your OB kit out if you can, have your ped bag available. But there are times like this where you just can't react. You can't get that stuff out quick enough, and that was kind of what happened for us. We didn't have anything out and ready, nothing prepared. Tony started talking to her, telling her to breathe. I decided at this point I better go down and make sure that we didn't have any crowning. We actually did have crowning. I communicated with Tony, and he's telling her to breathe actively, not to push. And she basically said, "Heck with you, I'm going to push." So she pushed one time, and I delivered a blue baby. Baby, again, like I said, was about 30 weeks gestation. Baby was about 2 pounds, 2.5 pounds. APGAR score at this point was about a 1. So we actively have now a baby that we have to resuscitate in the air, in flight. And we're about 3 minutes out from landing at Campbellsville, which is Taylor Regional Hospital. So at this point, we have to make a decision. What are we going to do? Now we have 2 patients. We have 2 of us as clinicians, and we have 2 patients. We have a baby now that's blue, and we have to react. We have to do things correctly. We have to work as a team. So we land at a small hospital pad. Like I said, the APGAR score was about 1. The baby had no respiratory effort whatsoever. He was blue. He really had no grimace. Brachial pulse, I really couldn't feel one. I could feel a small umbilical cord pulse, and I would say pulse was around 60 at that point. So I immediately started compressions, right? So you start compressions immediately, and I asked Tony to get me some towels. And one of the things that's kind of funny about this whole thing is I don't know where he came up with the towels, but all of a sudden he threw towels and they hit me in the face, right? And I asked him for suction. Really didn't have, like I said, the OB kit out and ready. This happened so fast, and he gave me an adult Yanker suction catheter. Ended up not using it. So let's talk about the whole suction aspect. With the new NRP guidelines states that we don't suction any babies born anymore. In the past we would always suction the mouth first and then the nose, but now we don't do that. We only do that if the baby is very stressed with meconium staining, right? They have to have a whole bunch of meconium in the mouth. That's the only time you're going to ever suction the child. So, at this point, we have to again make a decision. We're landing at that facility. We landed, and Tony jumped out. He grabbed the OB kit out. Like I said, we were about 3 minutes out of that time. He's up near me, and we've got the airway kit out. We've got all that stuff out, and we decide to clamp and cut the cord. So we clamp the cord, and remember, when you clamp the cord at least 8 fingers above the stomach. Give yourself a lot of room. Give yourself a lot of room to have to cut that cord down if you need to. We ended up needing that, but you also have to think about the care after you drop this little baby off, right? They may have to cut the cord down as well. So give yourself plenty of room. Don't cut it really, really short. Remember, as far as anatomical differences of kids, the big thing is this little guy, weight-wise, is really, really tiny. Remember, for every 500 grams, that's 1 pound. So for weight, basically, if it's less than a year old, it's age in months plus 9 divided by 2. Or another way is age times 2 plus 8 is a probable weight. But obviously, this is a little guy less than a year old. And then BP, if the baby is less than gestation. So, right, this is a neonate, baby was born premature. It's basically the gestational age in weeks, and that's going to be the neonatal's MAP. That's the MAP goal, minimum MAP goal. So the minimum MAP on him, if we were to check a blood pressure, would have been 30. Remember, as far as a full-term little guy, hypotension, that systolic is 70 plus 2 times the age. So if it's less than that, then they're hypotensive. And a normal blood pressure is 90 plus 2 times the age. Your ET tube, remember, we always want to use a Broslow tape. For these little guys like that, it's probably going to be like a 2.5 or 3. For most pediatrics or little babies like that, you can always intubate them with a 3.5 or 4. I mean, that's going to be pretty standard. But always use your Broslow tape. Pull that out. Another way to do it is calculate age plus 16 divided by 4. The NG tube, the Foley catheter, the suction catheter, you can actually just double the ET tube size, and those are your calculations. So double that, and that'll give your NG, your Foley, your suction. And you can actually quadruple that if you were to place a chest tube in this little guy. You could quadruple that ET tube size, and that's going to give you your chest tube size. Remember, as far as airway goes, that these little guys have a very, very narrow glottis. They have a very big head, so we always want to try to pat under the torso, bring them inline neutral to give you the best optimal view and success. So back to our scenario. So at this point, we're kind of in a situation where we've clamped the cord, we've cut it, and we actually landed on AirEvac 43, which is Campbellsville. We landed on their pad. Their aircraft was in the hangar. And the flight crew came out, and they were very, very great. The pilot came out, the flight crew came out, and the crew stayed with the mom. So the mom stayed in the aircraft. The crew delivered the placenta. And the pilot actually for AirEvac helped Tony and I. So kind of paint the picture. Taylor Regional is a really tiny hospital. It's got a small little OB unit. It's kind of one of those local community hospitals. And it's about 150 to 200 yard walk from the helipad. So we, like I said, had clamped to cut the cord. I had handed the baby to Tony. At this point, APGAR score is probably about a 3. We've improved a little bit. We've dried and stimulated. We're doing positive pressure ventilation at this point. Remember, anytime you have a low heart rate based on NRP guidelines, the first thing you always want to do is try to give 1 minute of positive pressure ventilation. As far as this goes, I didn't have that capability at that point. I immediately just started compressions until he was able to give me a BVM, and at that point, again, I was by myself. So until he was able to move up front to the aircraft when we landed. Like I said, that was only a minute and a half by the time we actually landed. And so, I was giving good compressions and trying to give blow by and until he was able to take over compressions, and I continued with a positive pressure ventilation. So we're walking now. Tony's carrying the little guy. Obviously, we want to always take care of the temperature aspect. Remember, little guys like this, they have 2 issues that we don't have. They have no brown fat. And that brown fat is very, very important for thermal regulation. They also have a very immature or non-functioning hypothalamus. So that's why these little guys can't regulate their temperature very well. So we have to always think about drying them and then get rid of those wet towels and put warm or I should say dry blankets or towels around them. Always try to cover their head because they're going to lose a lot of heat out of the head. So we're walking down the sidewalk right now, middle of July. I'm walking backwards. Tony's walking forwards. He's carrying the little guy. Tony's bagging, I think, and I was doing compressions or vice versa. The AirEvac pilot, like I said, was very, very good. He actually had an O2 bottle attached to the BVM, and he's carrying the O2 bottle. So let's talk about that. The new NRP guidelines have changed quite a bit since this flight. And one of the things that we have to think about is our resuscitation points. And resuscitation points for these little guys, we've talked about ET tube size. We've talked about, remember, the tube depth is going to be 3 times the ET tube size. That's the depth that you want to kind of gauge for. We use cuff tubes now, which is a good thing. Remember your IV attempts. IV attempts need to be limited. So depending on how unstable this little guy is, keep those IV attempts limited. If you can't, go straight for an IO. But when we talk about your O2 sats or maintaining oxygenation, now this little guy, like I said, was blue, APGAR score of 1, and had a was very, very sick at that point. And based on NRP back then, we gave positive pressure ventilation based on 100% FiO2. And that has changed. And now what they want is they want you to maintain the lowest amount of O2 based on ductal O2 sat. And your ductal O2 sat is, you got to make sure that you always put your sat probe on the right hand, right? Because that's preductus. And you want to maintain a ductal O2 sat. Remember that in vitro, when the baby is actually getting oxygenated in the mom, that's happening by a completely different process than we normally oxygenate our lungs. And the oxygenation is actually happening based on the placenta. So the right side of the heart is actually the high pressure side instead of the left side. And you and I, sitting here right now, we have the left side as our high pressure side. Because of this, most blood in the right atrium actually moves to the right ventricle via what's called the foramen of ovale. The blood then actually moves into the pulmonary artery. But because we have very low oxygen, we see pulmonary arteries that are closed. All right, so pulmonary arteries are closed. The blood can't go through those pulmonary arteries into the lungs. And at this point, instead of doing that, they go through what's called the ductus. And the ductus arteriosus is then your funnel into oxygenating the rest of your body. So instead of going through your lungs and going through the normal process, our placenta actually oxygenates that blood, and we go through that foramen ovale. We actually bypass the pulmonary arteries because they're closed, and we go through the ductus. And that ductus closes when we are born based on oxygenation. Once we start breathing oxygen, that ductus slowly closes, and we actually transform from that ductal flow to the proper oxygenation. And obviously, when these babies are born, they're immediately switched over, but that ductus takes a while to close. And what they've identified is, you don't want to close that too soon. And so giving high concentrations of oxygen like that will actually close that ductus. It'll close that ductus very, very fast. So the whole goal is based on a 1 to 10 minute guideline. So at 1 minute, you want your O2 sat to be between 60 and 65%. And that's right, 60 to 65%. If you haven't taken the 2 new NRP guidelines, that's what your goal is. So that means you're not going to want to give high flow oxygen. If the baby has a good heart rate in normal ranges, you're not going to want to even give any oxygen at all. Just let them be at where they're at. It's all right that they're a little bit hypoxic like that. They've lived at those ranges. At 2 minutes, they want to be at 65 to 70. At 3 minutes, 70 to 75. At 4 minutes, 75 to 80. At 5 minutes, 80 to 85. So at the 5 minute mark, their O2 sat still is between 80 and 85%. And it's not even until the 10 minute mark that we see an 85 to 90% O2 sat. So just kind of keep that in mind. You can check that out in the NRP guidelines. Look at the new book, the new guidelines, and check that out if you're not familiar with that. Okay, so at this point in our scenario, we're walking down the sidewalk. We don't give them any notice that we're coming in. Again, this happens so fast. And we bust into this ER, right? So imagine you're working in this ER if you're a nurse, and you have a flight crew bust in with a 30-week neonate at a tiny little community hospital. So as we arrive in the ER, we immediately see a room off to the left, and we go right into that room. We're carrying our bags. We have our bags. We have everything we need. We're not going to rely on the ER. We're not going to rely on anybody else. We're going to take care of our patient. And the nurses were really, really good. We had a couple of nurses come in and assist and ask us if there's anything we need. At this point, we do a reevaluation of our APGAR, and our APGAR at this point is at 5, right? So we're improving, we're getting better. His color's getting better. He's not as blue. His heart rate is hovering right around 100, I believe. So, we're doing pretty good, but the patient has very low respiratory drive. So we make the decision to intubate the patient. So we intubate the patient. I intubate first pass success, and I believe we used a 2.5 ET tube. But during securing this, both of us have very, very big fingers, and we actually dislodged the tube. For this little guy, a 2.5, we didn't have a cuff tube. This was an uncuffed tube. So we actually extubated him, and then I did a second intubation attempt and got it. We secured the tube, and then we started assisting ventilations with our little BVM. So what are your other treatment options? What other things should we be thinking about? Remember that these little guys have very low glycogen stores, right? So any stress response from a little guy like that, you're going to see a sugar spike. But for him, just coming out, he's probably going to have a low sugar, right? If you ever transport a little guy, always check a blood sugar a couple times. I would check it immediately when you get in the hospital room if they haven't already done so. And what I have found on all the little guys I've transported is a lot of times you're going to have a huge spike in sugar. It may be 150, 160, 180. But if you see that, that is a stress response, and they're releasing all that because of that response. Remember that their capability or their ability to actually shiver and produce heat is very limited because of the poor hypothalamus regulation that they have. It's not developed, and they have very low amounts of brown fat. So always think about that their shivering is going to be regulated by their glycogen stores as well. If they can't shiver because of low glycogen stores, then they're going to get behind on their heat really, or their temperature very, very quickly. So blood sugar is one thing. How are you going to place this patient on the ventilator? How are you going to give them fluid volume? How much volume are you going to give? Remember, neonates were at 10 mils per kilo as far as your initial bolus, and we want to give those boluses and then give them some type of maintenance infusion. So we give 10 cc's per kilo, another 10 cc's per kilo, another 10 cc's per kilo. So like I said, he was about 2.5 pounds or so. I think we kind of estimated him at 1.5 kilos around there. So you're not giving very much. But then we have to think about the whole IV attempt. Now, in this situation, we immediately had an OB nurse come from the small little OB unit. She brought an isolette. At this point, there was no physician in the ER that ever came and assisted with us or helped us. We just, like I said, had those two nurses. So we moved the little guy to the isolette, and we rolled him back to the OB unit. And within about 10 minutes of the OB unit, there was an OB doctor that showed up, which, helped us at that point. It was very, very great. We did attempt a umbilical vein catheterization, and we were unsuccessful. One of the things I remember is that we really had very, very poor access ability. We cut that down a couple times to kind of give us a better view, but our catheters that we were using just weren't small enough, and we just couldn't get it to pass. So I learned a few lessons, and I had another delivery since then, and I again tried to, or I should say we tried to do a UV catheterization as well, and it was unsuccessful for the same reasons. It just would not go in. So it's not like it is in training, if you've ever done it in training. I talked to some neonatal nurses that deal with this all the time, and one of the things that they told me is that you're only going to be successful with a UV catheterization if you have a baby in profound shock. That vein is going to be constricted down, so really, really tough to pass anything through there. It's only when it's dilated out that you're going to be successful. So in both of the instances where I've had a little neonate or a little baby where I've had to get an IV on, we've actually gone to a second attempt and got an AC in the with a 24 gauge, 22 gauge first attempt. And that's exactly what happened in this situation. Tony, at that point, after I was unsuccessful, he said, well, I'm going to look. He tried an attempt with a 24 gauge and got it immediately. So we checked the blood sugar. His blood sugar was like 30, and we decided to give him D10. Remember, giving D10 like that, you want to really dilute that down. You want to dilute that sugar down. So take your D50 vial, expel out 40 mils of that, draw in 40 mils of normal saline, and now you have D10, and you're going to give about 1 mil per kilo. So very small amount. At that point, though, you got to remember that these kids are going to burn through that, and so you need to put them on a maintenance infusion. And the fluid maintenance formula, you're going to use that 4-2-1 rule, where from 0 to 10 kilos, it's 4 mils for every kilo. So again, we would never go above that, right? 4 mils for every kilo. He's 1.5 kilos times 4, so he's getting about 5.5 mils per hour. Very, very tiny amount. If you continue with that 4-2-1 rule, if they're greater than 10 kilos for the next 10 to 20 range, so if let's say they're 16 kilos, right, the first 10 is going to be 4 mils per kilo. Then we have 6 is in between that 10 and 20. So that's going to be at 2 mils per kilo. So 6 times 2 is going to be 12. So for a 16 kilogram patient, we have a 52 mils per kilo D5W. And so on these little guys like this, you want to give D5 like in a half, D5 and a half, D5 and a quarter, something with a sugar in it. All right, so they can have that maintenance. They need that sugar. They need that fuel. All right, so at this point, we can discuss as far as your ventilator strategies. For these little neonates like this, we have to remember that these babies are very, very tiny. Our transport ventilators only go down to 50 mils on volume, whether you're using the Revell or the LTV 1200. So you got to start on pressure. And for this little guy, starting on a pressure of about 10, looking at that exhale tidal volume, and identifying these are going to be tiny, tiny little tidal volumes. So if he's 1.5 kilos, you're going to be probably at an 8-9 mils on your tidal volume, very tiny tidal volumes. Respiratory rate on this little guy probably should be between 24 and 30, right? They're going to have a higher rate. Your eye time is going to be really, really short, right? Tiny little eye time, 0.3 to 0.7 seconds. And then your PIP and your plateau pressures are going to be exactly the same as you and I. You want to maintain a PIP below 35, plateau pressure below 30 in this circumstance. Now, at this point, the baby's APGAR score is really, really good. It's up about around an 8. His heart rate is looking about 130. We've given the sugar. We've got an IV established. We've given him a fluid bolus based on the 10 mils per kilo. We've got our maintenance infusion going of D5.5 at 6 mils per hour. The other thing you want to look at is if you have the ability, obviously we didn't, is, make sure that their labs are appropriate, right? A lot of times these little guys, their calcium is going to be low. If their calcium is low, their phosphorus is going to be high. There's always a relationship between the two. So make sure their calcium is sufficient, make sure their magnesium is sufficient, things like that. Obviously in this situation, we didn't have that capability, but that's something to always look at if you have a transfer of a little guy like that. Okay, so at this point, the little guy, he starts kind of being restless, and he extubates himself. Couldn't figure out how he did it, but he extubated himself. And so at this point, what we decided to do is because his APGAR score was so good, he was very pink. His heart rate was, like I said, in the 130s. He had a great MAP pressure. Remember, his gestational weeks. That should be his MAP. So his MAP, I think, was about 38. It needs to be about 30 minimum. We decided to put him on BiPAP. And BiPAP for these little guys is great. We're going to do a podcast specifically on BiPAP and the whole strategies behind oxygenation and ventilation failure coming up soon. But we placed this little guy on BiPAP. We put him on a BiPAP of about 7 and 3. And he did really, really good. Kept him on the BiPAP. We accessed our NICU team that we contracted with the University of Kentucky, and they flew down. And they really didn't have to do much. We had everything done. So this was a kind of one of those cases where this was my first delivery ever. 23 years in the profession, I had never delivered a baby. But things went really well. Things started out kind of stressful as far as we were surprised at this precipitous delivery. Happened in flight. At the time, it was one of the only in-flight deliveries that we knew of in the country. And, it's just not something you don't want this. You don't want this to happen. Luckily, we were in an aircraft that we could access the baby. I was able to go down all the way to the bottom of the gurney and sit there, and I had a lot of room. If you're in a 206, if you're in a 407, if you were in an BO105 or an EC135, and that happened, you may have a more difficult time to, number one, access the delivery, but also maintain care if you're in flight. So you always have to be thinking about what you're going to do, what aircraft you're in, and how to deal with that. The baby ended up doing really, really well. Like I said, transferred to University of Kentucky. Mom was actually discharged shortly after that, and he did really, really good. Like I said, this was about 4 years ago. He's still very, very healthy and doing really well. Couldn't have had a better partner in Tony Harrison. We worked really well together, and So hopefully this was kind of a cool case for you to kind of listen to. And like I said, we are going to do a podcast specifically on BiPAP. I think when you look at not only adults, but especially kids respond really, really well to BiPAP. And anytime we can not intubate either our adults or our little kids like that, it's the best option, right? So we're going to focus on non-invasive positive pressure ventilation, a podcast coming up on oxygenation therapy, or I should say oxygenation failure strategies and ventilation failure strategies. Like I said, share this podcast with your friends, with your coworkers, with other people. This is a very highly practical podcast. I hope everybody's continued to enjoy it. You know, our numbers are huge right now, which I just, like I said, so humbled by. We're up 142% from last year. So that is just amazing to me. So keep spreading the word. I thank you so much for listening. Check out the Second Shift podcast. You know, it's a little bit different than this podcast in that we joke around, we play around. We have a co-host in Mike Request that I think is very, very talented. And we just talk about trending things in research, in everything HIMSS, EMS, emergency medicine. We're going to bring on great guests and kind of get that collaborative aspect of looking at everything involved in our profession. So until next time, I want to thank you again, and I'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.